Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn, Medical Editor at MIMS Learning, and here with me today is Pat, our editor.
Hello.
Today we will be looking at sleep issues, discussing causes and potential management options. We will cover situations where patients feel that they are not getting enough sleep or that their sleep is disturbed, and conversely, how sleep can be affected in a way that the patient is not aware of. Okay, so I've never been great at switching off my brain when I need to sleep, but I have learnt some tricks for nodding off. For example, reciting the Kings and Queens of England, and I usually manage to drop off by the time I get to Henry VII. Anyway, Pat, what are your tips for dropping off?
Well, I'm impressed with your knowledge of the Kings of Queens. I grew up in Scotland, so I was never taught the Kings of Queens of England anyway, and I'm not sure I could recite the Scottish ones either, to be frank. So I'm blessed with good sleep usually, but caffeine is my nemesis, and I have to be very careful not to have too much, even in the morning, as it really affects my sleep.
But if you are struggling to get a good night's kip, you're not alone. Around a third of adults in Western countries experience sleep problems at least once a week, with up to 10% fulfilling the criteria for insomnia disorder. However, this may be an underestimate, as insomnia is thought to be highly unreported. Probably only about 30% of those affected seek medical advice. That does make me think about why insomnia is highly unreported, because if you've only got short-term insomnia and you know why you're not sleeping, perhaps you're going through a stressful time, then you're probably not going to report it.
Yeah, possibly. And how exactly we know it's unreported if people aren't reporting it is another question.
But what is the criteria for insomnia? Because it's more than just having the odd night of poor sleep, isn't it?
Yes, so the NICE clinical knowledge summary on insomnia defines it as a persistent difficulty getting to sleep, maintaining sleep, or quality of sleep, which occurs despite adequate opportunity and circumstances for sleep and results in impaired daytime functioning. So the key phrases here are that it occurs in spite of adequate opportunity and circumstances for sleep, and that it impairs daytime functioning. So a new parent probably wouldn't be classed as having insomnia, even though they may well be sleep deprived, and that deprivation is affecting their functioning, because newborn babies are notoriously associated with inadequate opportunities and circumstances for sleep. On the other hand, if you have limited sleep but it's not affecting your daytime functioning, then it's not insomnia.
And to expand on that, short-term insomnia is characterised by symptoms occurring for less than 3 months, typically just for a few days or weeks, while chronic insomnia is characterised by symptoms occurring on at least 3 nights per week for 3 months or more. But whether insomnia is short-term or chronic, it can be divided into different types. So GP Dr. Sunita Kochhar writes in her module on insomnia red flags, there is initial insomnia, and this refers to difficulties falling asleep. She adds that on average, people without insomnia fall asleep within 30 minutes. Then there's sleep maintenance insomnia, which is when someone has difficulty falling asleep after waking in the night. Patients may also report early morning waking or unrefreshing sleep. According to Dr. Kochhar, initial insomnia tends to be associated with psychological factors such as a stressful life event, while sleep maintenance insomnia tends to be associated with physical factors.
And Dr. Kochhar also discusses primary and secondary insomnia. Primary insomnia, as the name suggests, doesn't have a known cause. There may have been a trigger for insomnia, such as a stressful life event that's now resolved, but the sleep difficulties have become learnt. Then there's secondary insomnia, when there is an underlying psychiatric or physical condition.
So we know how insomnia is defined, and we've given a brief overview of the types of insomnia. Shall we have a look at the GP's role in all of this? So we've just made a reference to primary insomnia, but I suspect more often than not that insomnia is associated with something else, be that a psychological or physical issue. Because it can often be associated with something else, I don't think it would be the main driver of why a patient was seeking medical advice, or the only reason why the patient was seeking medical advice. A patient might mention poor sleep as part of several symptoms they want to discuss. But whether insomnia is the only thing a patient wants to discuss or is one of several things, what actually is involved in assessing a patient with insomnia, or a patient who says they have insomnia?
So according to Dr. Kochhar, the first step is to establish what a patient means when they're experiencing sleep deprivation. As mentioned, insomnia is when reduced sleep is having an effect on daytime functioning. So they may not have insomnia. It might just be the case they just don't need as much sleep as they're used to having. Dr. Kochar notes that the average sleep requirement changes with age. So most healthy adults sleep for 7 to 9 hours per night, but this varies, with the total sleep time decreasing as you get older. And the number of awakenings may also increase with age. So if your patient is reporting they keep getting up to go to the loo in the middle of the night, that could obviously be a sign of something like type 2 diabetes, overactive bladder, or prostatic enlargement. And I suppose whether that's a problem, apart from the management of those conditions, depends on how quickly they can get back to sleep after the nighttime excursion to the toilet. And then I suppose that falls under the sleep maintenance issues that we talked about earlier. If you, as the GP, do think it's insomnia, asking the patient to keep a sleep diary for at least 2 weeks may be helpful, according to Dr. Kochar. Such a diary can be used to identify any patterns that might be amenable to behavioural treatment. Diary should record times of going to bed and rising, time taken to fall asleep, nighttime awakenings, daytime tiredness, napping, sleep quality, and meal times. Ask about snoring and breathing patterns.
Okay, so a diary and taking a general history can help suggest a potential cause. Causes can be psychological, for example, anxiety, or physical. If you suspect that another sleep disorder, such as obstructive sleep apnea or OSA, is present, NICE says you should consider the need for referral to a sleep clinic or neurology. But for the moment, let's assume it's just insomnia. Dr. Kochar says that good sleep hygiene should be advocated. This involves fixed times for going to bed and rising, relaxation techniques, creating a comfortable environment conducive to sleeping, and avoiding daytime napping. If these fail and the daytime impairment is severe and causing significant stress, and the insomnia is likely to resolve soon, for example, there's a short-term stressor, according to NICE, a short course, 3 to 7 days, of a non-benzodiazepine hypnotic medication can be considered. However, if the insomnia is unlikely to resolve soon, cognitive behavioural therapy for insomnia should be offered. A hypnotic can be considered as an adjunctive short-term treatment. I'm sure our listeners know this, but just obviously with NICE recommendations, there is a difference between offer, which is something you should do, and consider, as in not absolutely necessary.
Good point. So that's insomnia. Let's widen our remit to other sleep disorders. You mentioned OSA, and we have a module on that written by Dr. Rohit Kumar and recently updated by Dr. Pipin Singh. And this says that OSA is part of a disease spectrum referred to as sleep disordered breathing, which encompasses central sleep apnea, snoring, respiratory related arousals, and hypoventilation. Patients with OSA have recurrent periods of collapse of the pharyngeal airway, which significantly reduces the airflow, either partially, hypopnea, or completely, apnea. The pharyngeal collapse is more pronounced during the period of sleep known as rapid eye movement, during which time the upper airway muscle tone is decreased. This reduction in the airway patency reduces the airflow and ultimately leads to hypoxemia and hypercapnia. As a result of this, the individual is roused from their sleep, leading to rapid return of the upper airway muscle tone, increased patency of the airway, and then hyperventilation to return the metabolic state to normal. These transient arousals, which can occur more than 100 times an hour in severe cases, lead to significant fragmentation of the sleep cycle, activation of the sympathetic nervous system, and ultimately a reduction in the quality of sleep.
That sounds absolutely terrifying. But as I made a reference to earlier, the individual may not know that it's happening. Sometimes it's their partner who alerts them that there's an issue. The module you mentioned has a case study, and that talks about Kevin, a man with OSA. So Kevin presents to his GP after his wife has been forced to sleep in another room because his snoring is so loud that it's keeping her awake. Kevin himself says he sleeps fine.
And in this case, Kevin didn't remember waking in the night. But further investigations after this GP consultation revealed that his oxygen saturations were falling as low as 76%.
We should just point out that while people with OSA can snore, snoring itself is not a defining feature of OSA. Someone who is snoring so loudly they are keeping their partner awake probably should seek medical advice, but they don't necessarily have OSA. The risk factors for OSA include age, male gender, and obesity. In fact, 70% of people with OSA come under the obesity category, which does seem a good time to plug our new editorial campaign, Confidence in Obesity Care.
Sounds great. Please tell me more.
Okay, so the aim of the campaign is to enable primary care professionals to support people living with obesity more confidently. The campaign features CPD modules from podcasts to in-depth clinical reviews on managing obesity and its related conditions, and includes this module on OSA.
And are these resources free to the learner?
Yes, so if you look at our campaign page via the link in the show notes, you'll see the range of resources on offer. And to add in another plug, we've got a webinar coming up on the 24th of February at 7 p.m. on simplifying obesity management in primary care. It features GP Dr. Pippin Singh and pharmacist Mutada Hussam.
I'm really looking forward to that one.
Okay, so going back to OSA, NICE says that clinicians should be aware of the higher risk of OSA in people who are obese, and they should take a sleep history and assess people for the conditions if they have 2 or more of the following features: snoring, witnessed apneas, unrefreshing sleep, waking headaches, unexplained excessive sleepiness, tiredness or fatigue, nocturia, choking during sleep, sleep fragmentation or insomnia, or cognitive dysfunction or memory impairment. Module notes the Malam-Patty score, the Epworth Sleepiness Scale questionnaire, and the Stop Bang questionnaire can all be used to assess the likelihood that a patient has OSA.
NICE refers to the Epworth scale scores, and in this scale there are 8 questions, and you arrive at a score of between 0 and 24. The module and NICE state that an Epworth score of greater than 10 should prompt referral to secondary care, but a lower score does not exclude OSA. Therefore, suspicion of OSA should be based on history and clinical examination, as well as sleep assessment tools.
Now, obviously, the diagnosis and management of OSA does come under the remit of secondary care, but there is still a role for the GP. The module discusses the need for lifestyle advice. For example, if applicable, weight loss advice should be given with potential referral to a dietitian. However, when updating the module, Dr. Singh observed that the availability of the dietitian will vary depending on local protocols. He also noted that while reducing weight is important, the daytime sleepiness associated with OSA can make this difficult to achieve. Again, if relevant, smoking cessation advice should be given, and patients should be advised to avoid drinking alcohol in the 2 hours before they go to bed, and to generally avoid drinking excessively. Another aside, do check out my interview with Dr. Steve Brinksman about supporting people with alcohol misuse. He gives really good practical advice.
Yeah, I thought he was a great interviewee. So in terms of medication, patients should also be advised to avoid taking sedatives or sleeping tablets, and if they are taking these, you should be advised to reduce them to the lowest possible dose. So you could consider asking your in-house pharmacist, if you have one, to support the patient with this. This does bring us to the extremely important issue of tiredness and driving. Road traffic accidents are more frequent in patients with excessive sleepiness, with driving performance in people who are tired being comparable to those under the influence of alcohol. There have been well-documented cases of accidents, and GPs do have a responsibility to inform patients about the risks of driving while tired. The patient also needs to understand that they may have to notify the DVLA about their condition, but of paramount importance is that they must not drive if they have excessive sleepiness. There's more detail about OSA and driving in the learning module, so do take a look.
We've discussed insomnia and we've discussed OSA. We also have a module on night sweat red flags, which immediately makes me think of the menopause. I'm perimenopausal and currently experiencing night sweats, and it really is quite grim to wake up feeling drenched in the middle of the night. It's quite annoying though, because I never really feel hot, so I still feel cold when I wake up. Anyway, the British Menopause Society states that sleep disturbance is common during menopause, with increased prevalence of sleep disorders such as sleep-disordered breathing, restless leg syndrome, and chronic insomnia. Importantly, the Society notes that untreated sleep issues can exacerbate menopause symptoms, reduce quality of life, and increase cardiovascular risk. It also states that sleep disturbances during menopause often have multiple contributing factors requiring a comprehensive, multidisciplinary approach to management.
So menopause is one potential cause of night sweats, but they can also indicate complex infections such as tuberculosis or HIV, a reaction to drugs such as hormonal treatments for prostate cancer, and malignancy such as leukemia or lymphoma. To help understand what might be causing night sweats, the module outlines several questions to ask patients. These include asking how long the night sweats have been an issue, what other symptoms they may be having, and whether there are any other lifestyle factors, such as smoking or drinking habits, that could be contributing. If you think menopause might be causing the night sweats, you should specifically ask about other vasomotor symptoms, such as hot flushes, urogenital symptoms, such as vaginal dryness, or mood disturbance. The answers to these questions can help determine what investigations are needed. For example, a plain chest x-ray if you think a chest infection might be causing the night sweats, or the HADS score if you suspect anxiety.
Okay, so we've now looked at insomnia, OSA and night sweats. Let's look at our takeaways. With insomnia, a diary and taking a general history can help suggest the potential cause. Causes can be psychological, for example anxiety, or physical. If you suspect that another sleep disorder such as OSA is present, NICE says that you should consider the need for referral to a sleep clinic or neurology. Talking about OSA is strongly linked with obesity, and healthcare professionals should be aware that people with obesity are at increased risk of the condition. Although the diagnosis and management of OSA falls under the remit of secondary care, primary care professionals still have a role. They can provide people with suspected OSA lifestyle advice, such as support to lose weight where relevant. Night sweats have multiple potential causes, including menopause. History taking can help point the way to a potential cause and indicate which investigations should be performed. Thanks for joining us today. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Don't forget you can claim a CPD credit for listening to this episode. Simply head over to the website version at mimslearning.co.uk. Join us next week for more clinical insights and fascinating facts.